So, we start with local anesthesia, going on the buccal aspect. We use articaine with vasoconstrictor 1 to 100,000. It is very important to give the anesthesia slowly to avoid having swelling of the soft tissue, and we can go lingually either in the lingual pavement or very superficially on the lingual aspect of the second molar. Always remember the position of the mandibular ramus to decide the flap design. We always go and do a palpation of the vertical aspect of the ramus to see where it diverges towards the buccal aspect, and we see that we found it, and it doesn't go directly in correspondence to the second molar, but is quite distal and buccal. So the flap design is going to be intrasulcular, a triangular flap with a releasing distal incision that has not to overcome the sulcus in between the vestibular and lingual cusps, and has to diverge on the very buccal side aspect, and it has to be a full flap incision. So we test that the anesthesia has performed its effect. We ask the patient if he feels just some pressure or some pain. As we said, in almost 90% of my surgeries, I don't do any more full block anesthesia. We see the ischemia of the vasoconstrictor. We check that there is no pain in the maneuvers that we are applying. Now we are ready with our scalpel to draw the incision we had planned intrasulcular till the distal part. We don't overcome the sulcus in between the cusps from the vestibular and the lingual aspect, and from this point, so from the distal buccal cusp, we diverge buccally and distally towards the ramus, trying to feel that our blade touches the underlying bone. And this is important to elevate a full thickness flap with its periosteum without leaving periosteum attached on the bone. So now we are ready to detach and elevate the flap using our elevator, which we use using the concave part towards us. We try to find the correct bone plane, and once we find the correct bone plane, we pull towards the buccal aspect as if we were opening and turning the page of a book, and we see that our impacted tooth was directly under the mucosa. We have to find where the periosteum detaches, and once we find the detachment of the periosteum, then we can follow and insert our elevator, pushing it on the buccal side to elevate a complete full thickness flap. And we know that these teeth that have had inflammation can have inflamed tissues superficially, which aren't always easy to manage. So we have to be very gentle, and once we find the correct separation plane, then we are ready to protect the soft tissues. But now we feel that there is tension in the flap that we have designed, so we have to continue our elevation, trying to remove the tension, because we know that we have to have a tension-free flap elevated in order to avoid laceration of the soft tissue, for example, towards the papilla, the mesial papilla of the seventh tooth. So once we found the bone aspect, then it's easy to pull backwards the flap and the periosteum in order to have the correct vision of the tooth. Always rinse to see and to remove any blood from your vision, and we also always have to have a clean and blood-free aspect and vision of the surgical field. Now what we do, we don't detach the lingual flap, but it's just a matter of inserting a retractor in order to have a protection. So we just gently push on the side the soft tissues in order to have the protection during our drilling procedures. We don't have to detach the lingual flap in order to avoid risks of lingual nerve injury. We give the retractor to the assistant, and we tell the assistant, and we look on what the assistant is doing to refrain from going too deeply inside the lingual sulcus, because this could create a compression on the lingual nerve. We see that there is a little bit of tension, so we decide to elongate the distal releasing incision, and this gives us the possibility to have a major visibility without pulling too much with our Langenbeck retractor. So we see that once we elongated the releasing incision, everything is better in vision, and this is very important for the post-op healing and the post-op consequences. So now, with a round bar on a straight handpiece at 40,000, we start to drill. But remember to remain in the correct axis when we're drilling. So always keep the stem of your bar parallel to the protector in order to avoid damage of the soft tissue. Always work under saline solution irrigation. In this case, the irrigation is a little bit reduced in order to have a better vision of what the camera was showing. Now, with our round bore, we create the buccal access sulcus, and this enables us to see and expose the crown and helps us to start with the odontosectioning. Odontosectioning that is done after that we perform a little bit of bone sectioning a little bit deeper with the Fisher bar, which has a diameter smaller than the round bar. So we created the space, and now we are ready first to perform and try a luxation to see if there is a movement of the tooth. And this gentle movement is not done to extract the tooth, but it's done to see if there is mobility of the tooth, and this helps us to mobilize also the apical part of the tooth, and in case of root fracture, it will help you later on in the surgery. So now we are ready to perform our odontosectioning, which is done with a Fisher bar under constant irrigation. Always remember, in these cases, you can start from the buccal aspect and you don't have to start in the middle of the tooth, because we know that there is no connection between the inferior alveolar nerve and the tooth. So we cut the tooth, and we always have to remember to remain inside the tooth. So the depth of our drilling has to go in the pulpal cavity, but we have to remember not to overcome the lingual aspect. So always remain inside the tooth and remain that small bridge, that animal bridge that prevents us from lingual nerve damage. So we have made an odontosection which is quite deep in the pulpal cavity, and then we have to fracture the two components that we have separated using a straight lever. So we enter our section, we tell the patient that we'll hear a noise, a creak-crock, and this permits us to separate the two fragments. And then we start the luxation, and we have to see if we have performed the correct odontosectioning, separating root and crown, mesial and distal, or just the coronal part. So we start luxating, always gentle movements, don't use too much pressure, and in some cases you can use some clemmer forceps to pull our tooth out and to see that the tooth is complete. So we know that we have removed the root and the crown of the distal aspect of this tooth 4.8. And we see also some soft tissue, which is follicular tissue, that has to be then removed before we start our suturing procedure. And now the luxation of the mesial part of the tooth, both of the crown and the root, and this is used to push the tooth aside, and then always using a small forceps, we actually move and pull the tooth outside of the cavity of the sulcus, and then what I usually do, I attach myself to that soft tissue in order to remove as much of that soft tissue with the tooth, so that I am sure that none of that soft tissue material remains in the cavity. And this is very important to avoid having problems in the post-op period. So once I remove the tooth, I check the apex of the roots. In this case, the tooth had still open roots because the patient was young. And now I start with my rinsing of the cavity to look inside for any fragments, root fragments or bone fragments that have been detached, that are very important to be removed in this phase. So abundant washes and rinses, and you see soft tissue that I will have to remove before I close my wound. Check on the apical aspect to remove any fragments. The assistant can gently pull the fragment so that I can go and remove it with a clemmer forceps or any other instrument that may be comfortable for you. So a good close-up to see the socket. Important to remove the soft tissue distally to the second molar, so that this helps us to have a good closure, primary closure distal to the second molar, and also it prevents from having pseudo pockets in the future. And then the removal of the follicular tissue around the tooth. It is very, very important to remove this tissue. But we always see that there is bleeding inside the alveolus, and this is also very important to avoid from having dry socket issues in the post-op period. Always check and go and scrub the bone with our Lucas spoon, which is a cutting spoon. It is obviously important to know the anatomy and do a correct diagnosis, pre-op diagnosis, to know that obviously if the inferior alveolar nerve is in contact with the tooth and we expect it to find it once we remove the tooth, it is very important not to go and damage it or irritate it with the spoon in these phases. So then we tend to see and recompose the original anatomy, and we are ready to suture. We are going to choose the correct suturing material based on different aspects that we have seen in the theoretical video lectures, depending on the anamnestic situation of the patient, depending on the oral hygiene of the patient, and depending on the collaboration of the patient, because we're going to remove the stitches obviously without anesthesia. So the assistant helps to keep back the primary flap. We enter from the buccal aspect to the inner aspect of the buccal flap, and then we go from lingual to buccal, not going too deep to avoid pinching the lingual nerve. We have to have enough tissue that is engaged by the suture in order to close the primary flap distal to the second molar. And we see that when we're closing and pulling the threads, the soft tissue completely seals behind the second molar, and this is perfect for the periodontal healing of our second molar. So in this case, the tooth was completely impacted in the soft tissue, and so we will perform a primary closure giving the original anatomy that was seen before starting the surgery. We close our knots. Remember not to cut the threads too short, because they could interfere in the phases of the healing process, going to fold inside the soft tissue, and that can lead to a difficult phase of stitches removal after 7 days. Then we keep our releasing incision straight and vertical so that we can give the correct anatomy in the suturing of the releasing incision. A single suture of the distal part, and then we're going to close a little bit more coronally the releasing incision. Okay, so always give a little bit of tension to the flap in order to engage the two parts of the soft tissue, and this will help us to close completely our wound. Always try to check not to have the knot that blocks the other threads of the suture, because it may give an incomplete closure of the knot. Okay, and so we have, after the third knot, a complete closure of our flap and our wound. And so everything looks just before we started the surgery. And then after that, a good compression with a wet gauze, and just before that, some dexamethasone 4 milligrams intramuscular to reduce edema, swelling, and post-op pain. And now the surgery is over. A gauze compression to check the hemostasis. Post-operatively, we keep it in compression for some minutes.